I'd like to welcome everyone to this latest installment of CADCA's Research and Action webinar series. I'm Jacqueline Brogdon, and I'm a member of CADCA's Evaluation and Research team. If you haven't previously participated in one of our webinars, the purpose of this webinar series is to introduce coalition members and substance misuse preventionists to current and relevant research being conducted in the substance use and community coalition fields. So just the most up-to-date information. And I'm joined for this installment by Marci F. Hertz. She'll present on her and her colleagues' article, Adolescent Mental Health, COVID-19 and the Value of School Community Partnerships, which was published in the Injury Prevention Journal in 2021. She's going to discuss how COVID-19 has impacted mental health and substance abuse, as well as how communities can leverage school community partnerships to address these issues. Since 2003, Ms. Hertz has worked for the Centers for Disease Control Prevention as a lead health scientist in the National Center for Injury Prevention and Control, and in the Division of Adolescent and School Health, also known as DASH. She's currently a senior behavioral scientist in DASH, focusing on promoting mental health and preventing substance use and violence in schools. Previously, she led the evaluation of an observational cohort study of medication-assisted treatment, the program evaluation of the core state violence and injury prevention program, and the implementation of the STRIVE program, also known as Striving to Prevent Youth Violence Everywhere. Prior to her work at the CDC, Ms. Hertz was the Associate Director of Violence Prevention Programs at the Harvard School of Public Health and a school counselor in DC Public Schools. She received a bachelor's in psychology from Emory University and a master's degree in psychology from the University of Pennsylvania. So we're very excited to have her here today. So now I'm going to turn it over to you to discuss your work. So I'm going to stop sharing my screen and you can start with yours.
Great. Thank you so much. Thank you so much, Jacqueline, and thank you for inviting me here this afternoon or this morning, depending upon where you are. I appreciate it. Let's get this started. So as Jacqueline said, my name is Marci Hertz, and I'm a senior health scientist at CDC in our Division of Adolescent and School Health. And my work in DASH focuses on mental health promotion and substance use prevention in school settings. We're a little different from some of the other groups you might have interacted with at CDC, and that we directly provide funding to local education agencies as opposed to local health departments. So as Jacqueline said, I'm going to start out providing a foundation of the data we had on youth mental health and substance use prior to COVID, review a little bit about what we know about the impacts of COVID on youth mental health and substance use, and then spend the bulk of my time talking about what I think is the heart of the matter, which is what can you as community coalitions do in partnership with schools to help prevent and intervene in youth substance use. So first, I'm going to start highlighting data from our 2019 Youth Risk Behavior Survey, or YRBS. So for those who are not familiar with it, this is a nationally representative survey of youth in public and private high schools in grades 9 through 12. And this is from our most recent trend report, where we looked at data from 2009 to 2019. And you can see here on the left of your screen for high risk substance use, the two key variables that we measured from 2009 to 2019 were actually trending in the right direction. That is, they were improving from 2009 to 2019. But unfortunately, nearly all of the mental health variables that we track, so you can see that persistent feelings of sadness and hopelessness, and all the suicide-related variables, save one, have deteriorated over that 10-year period from 2009 to 2019. And the only one that didn't deteriorate, making a suicide attempt that needed treatment by a doctor or nurse, actually remained unchanged. So to delve into that a little bit more here, you see with the substance use variables that in 2009, 20% of youth had said they used illicit drugs. And that number decreased to 15% in 2019 overall. We saw significant decreases among white and Hispanic students for this variable, but among Black students, this number actually remained statistically the same from 2009 to 2019. In terms of misuse of prescription opioids, we did not measure that back in 2009, which is why you don't have that comparable data point on this slide. In 2019, 14% of youth misused prescription opioids. This question was added to the YRBS in 2017, and the number was statistically the same in 2017 to 2019, around that 14%. And then you can see in the bottom right, two of those particular mental health related variables. You see tremendous increases from 2009. 26% of young people in 2009 had said they felt so sad or hopeless in the 2 weeks prior to the survey that they stopped doing usual activities, and that number had increased to 37% in 2019. And then you see making a suicide plan also increased from 2009 to 2019. Here we primarily see differences in gender, with more than 50% of girls, for example, saying they felt sad or hopeless over the 2 weeks prior to the survey compared to boys. And similarly, girls were also twice as likely as boys to have made a suicide plan. So I'm often asked why. Why do I think that we're seeing these deterioration in youth mental health? Why are we seeing this increase in youth misuse of prescription drugs, really any adult misuse as well? And while the answer is really likely a confluence of factors, one explanation are adverse childhood experiences, or ACEs. For those who might not be familiar with them, this term was coined in a landmark CDC study in partnership with Kaiser Permanente, where adults sitting in a Kaiser waiting room were asked to report on their experiences as children with physical or emotional abuse or neglect, as well as things like witnessing domestic violence or parental substance use, etc. And they found what we call a dose-response relationship between the number of adverse childhood experiences someone reported experiencing and the likelihood of these negative health outcomes that you see here on the screen. So as the number of ACEs shown in that light gray circle increases, so they have greater experiences, the likelihood, so the size of those circles increases. Their likelihood of experiencing any of these negative health outcomes as adults increases. And what I circled in purple for you on the screen here are the likelihood of drug use, but you can see the likelihood of alcoholism is reflected in that yellow circle, and smoking is reflected in that light green circle. So again, the number of ACEs increases, so too does the likelihood of drug abuse, substance use, smoking, and all of the other factors that you see here on the screen. I just wanted to highlight a little bit from the survey of youth in Minnesota. When you go to make your request of schools to work with you in partnership, I think it's important to come with data, and I'll talk about this in more detail in a few minutes. But in addition to making the case about you as a coalition working with the young people, I think there's a case to be made too for the school joining your local coalition. I know in most cases, if not all, a school board member hopefully is already part of your coalition. But we know that there's a relationship between substance use in the community and youth academic achievement, for example. So we know that living with someone who is using illegal drugs, that second point on your screen, or abusing or misusing prescription medications, is associated with high schoolers cutting 3 or more days of school in the past month, and below average grades defined as mostly D's or F's in this particular survey of youth in Minnesota. You see here some other data related to some of the demographic variables about housing instability associated with academic achievement or lack thereof, lack of plans to graduate. And all of these things are things that you can collaborate with schools to help address to improve substance use and academic achievement. So that was the foundation which we were operating on before the COVID-19 pandemic hit. Since the COVID-19 pandemic hit, we have some data. This is two longitudinal data sets that were in the field prior to the COVID-19 pandemic and then collected data during the pandemic. So one study of Canadian high schoolers did not find an actual increase in students starting to use substances, but they did find an increase in the number of days, in particular among girls, that they reported using alcohol or cannabis. They also found that 42% of those who said they had used alcohol or other substances reported using with their parents. 93% of those, right, who use substances said that they used with their parents, said they used alcohol. About a quarter of those reported binge drinking with their parents, and then lower percentages reported cannabis use with their parents. In the Canadian study, those who reported greater fears of COVID reported more depressive symptoms and were also more likely to use substances by themselves. And then the study on the right, the Adolescent Brain Cognitive Development Study, or ABCD study. This is a US-based study of younger kiddos, so those ages 10 to 14. And they found, trying to minimize my screen, seeing myself on my screen apparently changed the slide. There we go. Okay, so compared to pre-pandemic, fewer youth reported using alcohol, but more reported using nicotine or misusing prescription drugs. And then young people who endorsed that they were feeling extremely stressed out were over 2 times more likely to report using any substance than those who reported slight or no stress during the pandemic. And then referring back to the prior slide youth whose households lost income during COVID, which we know many folks either had reduced hours or lost employment entirely, were more likely to report using any substance than those who did not report a loss in household income during the pandemic. And I just wanted to note all of the data that I'm sharing, the citations. So if you want to learn more information, you're welcome to email me, but also they're at the bottom of the slide here. And then in terms of the relationship between substance use and mental health, this is data from my colleagues at SAMHSA. This is the 2020 National Survey on Drug Use and Health. You can see on that Venn diagram here that 5.1 million youth had either a substance use disorder or a major depressive episode in 2020. 3.5 million youth had a major depressive episode, but not a substance use disorder. And then you see 900,000 youth had a substance use disorder, but not a major depressive episode. And we know here that youth who had a major depressive episode in the past year were more likely to report illicit drug use. So you see this in the bars on your screen. So you see there's significant differences here, with nearly 29% of those with a major depressive order reporting past year illicit drug use, comparing to about 11% of those who do not have a major depressive episode. And we see here the same pattern for marijuana use, past year opioid use, binge drinking, and use of tobacco products or nicotine. So schools and community partnerships can play a really large role in substance use prevention. Over 77 million young people are in schools in the United States on a daily basis, and they're in a discrete setting. So they offer a wonderful opportunity for both prevention and intervention services. And I know that many of you are already working collaboratively with schools or attempting to do so in some form or fashion. I know it can be tricky. And so what I'm going to do now is highlight some tips or tricks for working with schools, and would love to hear what tips or tricks or things you all have learned in your work as well. Okay, so if you are not familiar with this document of how schools work and how to work with schools from the National Association of State Boards of Education, I provided a link to it on the bottom here. And on the slide are the key topics that are covered within this document. It is a wonderful, wonderful resource. I'm going to highlight some of the key points from that document on the next slide, but I really encourage you to download that document. It's immensely helpful. Okay, so some guiding principles about how to work with schools effectively. The first is to find out what the primary goals are of your particular state Department of Education or your local education agency. This can often be found by just Googling your local education agency and finding out what their goals are, Googling what their strategic plan is. However, I would caution related to the fourth bullet on this slide, not to make assumptions that just because something is the State Department of Education's plan or part of the district's plan, that is necessarily true for the school, the individual school that you might want to work with as well. So always presenting the information you have, but checking assumptions and checking in with your education partners are always wise. But as I said earlier, tying everything back to education is critically important. How what you're proposing to do can help them and their students spend time on task, how it can help improve attendance, test scores, grades, graduation rates, is all critical information to being able to get an entree into your school. And the more specific data you have to your district, the better. There is some data from, for example, from the Youth Risk Behavior Survey, and many other states have their own local surveys. So I encourage you to look into that as well. Concerns about safety. This was actually created before COVID. So here they were referencing concerns about violence. I would just add, in the age of COVID, some schools do have protocols in place preventing outside volunteers from accessing the building. So you might want to be prepared to pivot and have meetings or implement activities virtually. And then the only other point that I want to touch on here is that education decision-making is diffuse and variable. So before you embark upon an endeavor, for example, with a local school or even for the district, you want to check and make sure that you understand who has to approve your activity, what levels, and how long that process might take. I think people get a little disheartened when they have an approval from a school principal and think they're ready to go, and then find out, no, it needs 3 other levels of approval. So making sure you have that discussion up front is really critical. But I don't want to dishearten you entirely here. Education leaders recognize, and certainly more now than ever, that they need partnerships, that these are vital, and that they certainly can't go it alone. I wanted to highlight the model that we use when we fund our local education agencies to frame different opportunities for you to work with school districts. So what we fund is that health and wellness coordinator at the district level. But what we ask them to do is implement a variety of strategies related to that purple oval box. So related to quality health education, linkages to health services, and safe, supportive school environments. And our program evaluation has demonstrated that schools that are able to do these 3 things well are also able to impact all of those adolescent-related outcomes that you see on the far right, including mental health, including substance use, suicide, and violence-related behaviors. So I'm going to touch upon these 3 components in my next slides. So health education. So this is from an article that you can see at the bottom from the Journal of Adolescent Health, where they look to analyze state education policies related to alcohol, tobacco, and other drug use. So they scored them based upon how they aligned in 4 different categories. So these categories were knowledge of biology and behavior, knowledge of context, affective skills, refusal skills, and generic social skills. And then they gave states points by which the degree to which all of these things were required, the degree to which they were required in K through 12, and then they gave extra points if districts included the need to use best practices in terms of instructional delivery, so whether they were interactive or not. So you can see the dark green are the states that receive the highest score in terms of the state standards related to alcohol, tobacco, and other drug use. So here is an opportunity for you, if you're interested in working with the school, to say, hey, our state didn't do so well, or hey, there's room for improvement in our state standards here. Can I help collaborate with you in evaluating what our standards are and looking for ways to improve them? Working to improve state health education standards related to alcohol, tobacco, and other drug use is a really low-cost option, way for you to impact all of the students who are attending at least their public schools in your state. So I encourage you to take a look at what your state standards are. Another tool that I want to highlight here is our health education analysis tool, or HECAT. So if there's a particular curricula that you or one of your school districts is interested in implementing or is covered in your state alcohol, tobacco, and other drug use standards. You can assess the degree to which that particular curricula is aligned with the best standards. And you see here the health behavior outcomes on your left that are tracked in the HECAT. These are obviously adjusted. It's for K through 12, so it's adjusted by grade level. It's K through 3, and then 4 through 6, and then high school are the way that it's divided. So you can just implement this one module of the HECAT if you'd like, or they're actually modules across different health topics. And it can be completed online, or you're welcome to download a PDF version and complete it in paper pencil. But this is a wonderful resource for you as well to work with collaboratively with your local school district or school. So I just wanted to highlight, and I'm going to move through these very quickly, and I apologize for that, but I wanted to mention them. You can Google them, or you can email me if you're interested in finding out more about these. I just wanted to highlight some really exciting ways that community coalitions can partner with schools. This Prosper approach, and I have to admit, I had to Google because I just call it the Prosper approach, exactly what it stands for, because they were a little creative in their use of acronyms, but it's promoting school, community, university partnerships to enhance resilience is what Prosper stands for. But it's essentially community local coalitions and substance use professionals partnering, in this case, with state land grant universities and local school districts to team up and deliver both school-based interventions and out-of-school-based interventions with families. The Prosper model calls for use of evidence-based strategies, but it provides a menu so that these local teams can come up with which of these strategies might be most effective or useful in their community. They use the Strengthening Families program for their out-of-school model, and I think almost all of them selected life skills training for their school-based model. And you can see here they implemented it in 6th and 7th grade with the same cohort of students. They followed them from 6th to 7th grade, and they had long-term follow-up effects. They had effects 1-year follow-up, they had effects 4.5-year follow-up, and even effects at age 19, which were 6.5 years after they administered this program, in terms of lifetime effects for illicit drug use and misuse of prescription drugs. So this is a great program if you're able to implement that in your community. Wanted to highlight some of the evidence-based programs. So you could start running whatever program you have if you have a local strategy through the HECAT, or you can go to this wonderful website that my colleagues at NIDA have and use one of these, which is evidence-based. You might want to think strategically with your school district about universal strategies that are implemented to all the students in a given school or a particular grade, or high-risk students. So riskier students, they might want to do small group or after-school activities. The Coping Power program, for example, is often implemented in after-school programs. So that might be another way you can work collaboratively with schools, but not take time away during the school day. Okay, linkages to services. So I don't know how many of you are aware if your schools have local school-based health centers. There are about 2,000 school-based health centers throughout the United States. And the School-Based Health Alliance launched this new initiative for SBIRT. They have here, I have the infographic that they recently developed, indicating that students are 21 more times more likely to say they would visit a school-based health center for behavioral health, substance use or mental health that is, than they are to visit a community clinic. And students with access to behavioral health centers at student-based health centers report lower frequencies of substance use. So if you don't have a school-based health center, that might be something you want to approach your school district about forming. And some of the school-based health centers might offer things like physicals or other types of physical health services, but might not offer behavioral services, particularly related to SBIRT, for example. So you might want to lean in if they have a school-based health center and ask about whether they provide behavioral health services, including substance use treatment. And if not, perhaps that's a way that you can offer to assist or partner with your school district. Another way that you could offer to assist is just to train school-based health center staff on how to identify students who have substance use programs, screening instruments, or how to implement screens. A recent survey of school health center directors in New York State found that the majority of them did not feel comfortable implementing SBIRT or other types of screening activities. So again, school-based health centers provide an opportunity for on-site services in a way you can partner, in addition to just familiarizing yourself and introducing yourself to the school-based health center so they can use your community-based resources as a referral resource. And then student assistance programs. These have been around for a really, really long time. I worked in Washington, D.C. public schools in the mid-1990s, and these were around at that time. These are really based off of the Employees Assistance Program model, which you might be familiar with. Most schools have student assistance programs, but what I wanted to highlight for you in particular is that the student assistance programs actually require that schools engage with the community in all these different types of ways here, some of which I touched upon in my prior slide. But these all offer opportunities for you to partner with your school districts and to offer your services when you go in and make that ask of schools. And I should also say, in addition to student assistance programs decreasing rates of substance use, they also decrease rates of violence. So they're often something that schools are already doing and are happy to enhance what they're doing related to student assistance programs. Okay, the last of those three prongs that I wanted to talk about on our DASH model are safe, supportive environments. You may wonder how that plays a role in substance use. Well, in our evaluation of our DASH funded activities, we found that students who reported feeling connected to their school, and that's really just believing that their school's fair, that the teachers and the school staff care about them as people and not just as a test score, that students who reported feeling connected to their school, as well as connected to their family, but they were all less likely to endorse any of these risk behaviors shown in this down arrow, including prescription drug misuse, as well as illicit drug use. So any opportunity that you have to collaborate with your school to increase the feelings of student connection to their school or student feeling of connection to family is likely to result in decreases in adolescent substance use or misuse of prescription medications. And then I just wanted to tie this directly to misuse of prescription medications here in terms of non-medical use of prescription opioids here, that this study of over 61,000 adolescents found that those in a supportive school environment who had higher risk mental health. So if we go back to that slide I presented earlier from the overlap between major depressive episode and substance use disorder, we know that these things often co-occur. But even for those kiddos who have depression, who have anxiety, for those kiddos in particular, the highest risk kids, a safe, supportive school environment was even more important in terms of decreasing the likelihood of misuse of prescription opioids. So I just wanted to highlight some of what doesn't work in prevention strategies. I know some of these are appealing because it's difficult to get into schools for a long period of time. Some of the strategies I've suggested might be more time intensive, might be more cost intensive, but we really know from the literature what doesn't work. These scared straight assemblies, I don't know how many of you were part of those. I know I saw many of those when I was back in high school, but they're really not effective, and in some cases can actually be detrimental when they're done universally, so to all high school seniors, for example, because what the messages that some young people might get is that the speaker in front of you was able to survive. And that it's prevalent, that substance use is prevalent. So you have to be careful with many of these strategies. Personal testimonies from people in recovery, again, not effective. Myth busting, when you align facts with myths, studies have shown that what the kids are most likely to remember are those myths rather than the facts. So I would proceed with caution with some of these or with all of these strategies. Some of them, for example, the personal testimonies might be effective in a substance use recovery setting, but just is not effective in a universal setting, as I mentioned, for all students, for example, in a given grade. So really, that's the end of my prepared materials here for you. So I'm going to stop sharing. Here's how you can reach more information about the information that I've shared. Also, my direct email address is M as in Mary or Marci, Hertz at cdc.gov. And that's it.
Okay. Let me this. Sorry. Having some trouble sharing the screen here. Give me a second.
Want me to?
Oh, it's okay. I think I got it. Just need to down here. Okay, so we have some questions from CADCA, but afterwards we'll be taking Q&A questions. So if you have questions for Marci, please put them in the Q&A box. We would love to hear those, but they might get lost in the chat box just since so many people post in there. So please do put those in the Q&A box. So one of the first questions we have that CADCA wanted to ask was, why do you think the trends of substance use and mental health are moving in opposite directions? I know that I found that a little bit surprising, and so I'd like to hear what your kind of hypotheses are on that.
Yes, thank you. That is a really great question. And I'm not sure that this is going to be the most encouraging answer. So first, the data that I presented was collected in 2019. So that was prior to the pandemic. And then some of that data, right, was collected early on in the pandemic. That ABCD US-based study was collected 6 months in the pandemic. So I do think there is a likelihood that as young people return to social settings and return to school, we could see changes in those substance use related variables. We could also, the data I showed was high risk substance use, right? A select number of variables. So it could be, that some of the youth have shifted from the illicit drug use or the intravenous drug use to more marijuana use, and certainly to more vaping. I would hope that they would both continue to decrease so that they would both trend in the downward direction. So we will have to see. I would also just add that I think coalitions like CADCA coalitions, the Drug-Free Communities coalitions, the tobacco-free community coalitions, that there has been a lot of effort in the intervening 10 years to launch robust prevention efforts related to substance use. And unfortunately, we really haven't seen that related to mental health. So that's my hypothesis. I'd be interested to hear what some of your coalition folks think about that too.
Great, thank you for that. Our next question is, so many people who misuse substances often misuse them because there's this perception that they might help with anxiety or depression. I know one that comes to mind is marijuana, the belief that that might help with anxiety. How do you recommend combating these misconceptions, or where do you see that in your work?
Yeah, I think this is, excuse me, these are all excellent questions. So I think we've seen, as I showed in the data, the first thing is to tell young people that they're not alone who are experiencing anxiety and depression. Unfortunately, as I showed, we know record numbers of young people were experiencing those prior to the pandemic, and even more have experienced it since. So the first thing is to let them know that they are not alone. The second thing that I would say is there are already evidence-based approaches to decrease anxiety, and some of them are not complicated. There are things like meditation, there are things like physical activity, even going outside for walks. All of those things have actually been associated, particularly the walks and physical activity, with changes in endorphins in the brain and improved mental health. There are also more structured activities, cognitive behavioral therapy, and doctor-approved psychotropic medications can improve anxiety levels. The research about marijuana and other drugs improving anxiety, but particularly marijuana, is inconclusive at best. And in other cases, as you know, you have to keep taking more frequent doses or take more and more in order to achieve the same effect, which can have a detrimental impact in terms of starting to use other substances and have a detrimental impact in terms of physical health and academic achievement etc. So there are evidence-based strategies already out there to address and improve anxiety, and marijuana and substance use is not one of them. So that's what I would say. And again, the strategies that I presented here can help, many of those can help with those mental health problems and substance use.
Thank you. And so another thing that you talked about was health education standards in each state. And so I'm sure some of the coalitions probably in this presentation probably noticed that their state maybe was ranked poorly there. So what advice can you give them to how they can improve their standards?
Yes. So as you might have could tell from my enthusiasm when discussing that, I think this is a wonderful strategy, particularly because I mentioned it's low cost and can have a broad impact. So I do want to let you know that if you look up state policies NASB, the National Association of State Boards of Education.org, there is a state policy, education policy finder. So if you select health education, when you go to that database, you can find your state specific standards related to alcohol, tobacco, and other drugs. So you can have that information specifically. So having that would provide more detailed information about what is included specifically in your state education standards. So I would say having that information is helpful. Reviewing what the national health education standards are. Yeah, I'll put it in the chat. Reviewing what the national state education, health education standards are, and how your education standards that I mentioned are aligned or not aligned with those can be really helpful. Let's see. Let me make sure I don't mistype this at all. Can be really helpful in going to your state board of education in partnership with a local board of education or local school district is always really helpful. And then offering to work collaboratively with them to improve those is a really low cost effective way to potentially reach all of the kiddos in your state, if not directly in your local school or school district. And then just keeping in mind all of those caveats and tips and tricks I highlighted at the beginning in terms of approaching your school district. I want to say, I think a lot of folks already know this, but schools, like everybody else, are completely overwhelmed by COVID. They have massive staff out in particular right now. They're having trouble getting substitutes and things like that. So if you can push pause and maybe wait a month or so before approaching them, that might be a valid or more likely effective approach, and or coming in and offering support, like helping to review standards or directly providing training or directly implementing something, I think is more likely to be well received than certainly making an ask of school districts right now.
Those are really great tips. I'm sure they're all going to appreciate that. They're very hands-on and tangible. And so now we have some questions in the Q&A box. We do have a lot. People are clearly very interested in this subject. So we'll try to get to as many as possible. And we're just going to take them in the order of, when they came in. So they're actually not in order of when they came in. So that's not very helpful, but Zoom for some reason doesn't do that. Okay, so I'll just do the one that's at the top of my screen. So what type of prevention events are successful in your opinion?
Oh gosh, so it's hard with one-time events. I think just increasing awareness. So if you're going to go to a health fair or you're going to do outreach and just let the school know that you're available and what types of services you can provide and who the contact person is really helpful. I think there's often long wait lists. They don't know who to call, and certainly helping to make what we call a warm handoff, right? So call this person rather than just call this main number at an agency is really helpful. Knowing what the intake process is going to be, so what kinds of information they or the family are going to have available to provide is something that could be helpful. Again, longer term engagement. Some of the strategies I mentioned are 2-hour commitments, but they're 7 sessions, like the Strengthening Families one. So those types of things are generally more helpful. than a lot of the one-time things. That's why I was trying to focus on either state or local education, health education standards, because that's something that you can be working on collaboratively, but online, and not require you to go into the school, for example.
We have a similar question. So since you mentioned that fact sheets are maybe not that effective, what sort of media would you maybe recommend instead? What sort of things would be effective?
So I think it's all about what's included on the fact sheet, right? You don't want to start out by saying, sometimes the prevalence, how many young people are using can be misconstrued. Like, oh my gosh, everybody's using, right? So this is normal behavior. So you have to be careful. I think fact sheets have to be careful with what information they can convey, or to say, oh, some people use substances because they think it can improve weight management, or because it can improve anxiety. Again, it depend on an adolescent brain, right? Thinking, oh, I should try this. I'm having trouble with this particular issue. So I just want to say it depends upon what information is contained on the fact sheet. I think helping them understand tools or resources or other strategies to cope if they're experiencing stress or anxiety can be helpful information to convey to young people.
Okay, great. So Julia has a question. How do you feel rural communities and schools respond to youth substance use? So maybe like how, I think what she's asking is maybe how is it different from, an urban setting?
Yeah, I think that's a great question. One of the things I love about the Prosper model is it was tested in rural areas and city areas. So I think that Prosper model is something worth looking into. I think, we've seen different approaches in terms of prevention in rural areas, depending upon, and cities. And I think it just depends upon what you think is going to resonate with your community, and what partners you have and what services you have available to, right? In rural communities, we did a project, Teens Linked to Care, and there were just a lack of providers there, right? So we did a lot of work trying to get them to get hooked up with telehealth health services, and which were available and who were licensed to provide them, and to youth in particular, is also tricky. We've seen more of the fentanyl and opioid overdoses historically in rural communities, but now that's spreading everywhere. We've seen greater availability of naloxone and those kinds of things for those who are overdosing, in some cases in urban areas compared to rural areas. But in terms of prevention programming, I mean, in schools, all our school districts that we work with, at least, have been fairly open to substance use prevention. And honestly, it's been a bigger struggle historically, not these days, but prior to COVID, to get them to do the mental health related work as opposed to the substance use prevention, particularly if it's the universal substance use prevention, because most of them already have this incorporated in some way in health education. The problem is they're often not using effective health education curricula to address substance use.
Someone else asks, could you clarify what you mean by reinforce exaggerated social norms on your kind of what not to do slide?
Right. So, if you present data, the data that I often think of that you put in a grant application, right? Saying, oh my gosh, look how prevalent marijuana use is in our community, right? Over 35% of kids say that they had used marijuana in the past month. Providing that kind of information on a fact sheet targeting youth is not always appropriate, because they're like, oh my gosh, see, this is the norm. This is what the cool kids are doing. Almost everybody's doing it. So therefore I should try to do it, or me doing it is normal adolescent behavior. So that's what I mean about putting that kind of information into a youth fact sheet is not helpful. It's very helpful when you go to your school district, right, and try to partner with them to share that kind of information. But again, it can backfire on you when you include it in youth specific or fact sheets targeting youth specifically. Thanks for that point. I'm glad I was able to clarify. I don't want that to be misconstrued.
Yeah. So Melissa asks, do you have tips for engaging parents? I think this is a big one for coalitions, so that's a great question.
I think that is a great question. I think, one of the tips and tricks I learned when working with the school district is to try to tie my efforts to existing school events so that I'm not asking them to come to something separate. So I often tied my event to before or after a school event. And I also always offered food. And to the extent you can provide childcare, I think it's a little harder with COVID these days. Hopefully next month things will be a little bit better on that front and we can have a greater opportunity to do that. But I think the other thing is recognizing that parents are doing the best they can under challenging circumstances, and addressing parents' own mental health and stress is often really, really instrumental in helping them support their young people. Their children. You saw on the slide that I presented about school connectedness that it also had family connectedness, and parents' ability to help support their children and to do interactive activities with them and just talk with them is related to their own stress and anxiety. So opportunities to help support parents are often helpful. I will say that in addition to the food and babysitting, any kind of other incentives that you could provide would be helpful. When I was working in a school setting, we even did stuff like offered folks on site to review resumes in with them and provide job training or access to computers or things like that were often things that were incentives for them to come and participate.
Okay, so just for the sake of time, we'll just do 2 more questions. And since this one is kind of related, so it's a long question, but I'll kind of sum it up. So one of the things you talked about, right, was ACEs, and one of the aspects of that is like adults' substance use in the home. And so how do you anticipate that maybe and then ACEs can cause, in the next generation, increased substance use. So how do you maybe see those numbers growing over time? I'm sure, especially with COVID, people being home and maybe witness to some more things that their parents are doing where they maybe would have been at school before. How do you see that maybe changing over time?
Yeah, I can say, and this was a paper that was published as an MMWR back in March that we released. We did a survey of parents of kids ages 5 through 12. The kids were ages 5 through 12. And we asked parents about their own mental health and their own substance use during COVID, and asked if they had started or increased substance use. And we did see a small but percentage that had indicated increasing or starting substance use directly as a way to cope with the stress related to the COVID-19 pandemic. So I think we've already seen those increases. I'm hopeful that some of the things that we've seen, like flexible workplaces for some people, will be helpful in mitigating stress. But I know particularly for those folks who work hourly or who are essential workers and doing essential functions, they don't have that flexibility. And now they have to juggle that with, for example, school being closed because of an outbreak, or their child being home because they've been exposed or they have COVID. So unfortunately, I think that I think we're going to be seeing the effects of COVID in terms of adult and youth mental health and substance use for several years to come. I will say I am encouraged by CDC and just general broader government response in trying to put together plans to help build community resiliency. And I sit on one of those Health and Human Service broad committees related to that. But that's why I think the work of your coalitions is going to become even more important moving on. And I just want to take this opportunity to thank you all for doing the hard work at the community level. I can only imagine how difficult and challenging it is. But I think it's going to become, it was always important, but it's going to be of increasing importance in these next few years.
Okay, and then the last question is from Brian. He wants to know, is there any ongoing research regarding youth perceptions of medical applications of marijuana in those states that have recently maybe enacted those changing laws? So, maybe some differences you see in those states versus ones that don't have those.
I'm not familiar with it. I know Colorado, I don't know if there's any Colorado folks on the phone. I know the Colorado Public Health Department was collecting a lot of information about that. So I can research that and put the link in there, but I know Colorado in particular, just from my prior work at CDC, was collecting a lot of that data and information. But I don't have that in the top of my head that I can share with you right now. And I know Colorado, right, it's not just specific to medical marijuana. So you've got to look at those nuances, medical marijuana versus just broadly legalization of marijuana as well, because there are differences there as well. But that's a great question for which I do not have a good answer, but I'm happy to look into it and get back to you. I will say our Division of Overdose Prevention at CDC is a wonderful resource for you as well. And I'm trying to think, I think Wendy Foote is the lead of the branch that addresses marijuana prevention in particular. So if that's something that you're interested in, I'm sorry, it's Brooke Hoots. See, I got it completely wrong. Here we go. Let me copy and paste her name here. She leads our marijuana prevention work in the Division of Overdose Prevention.
Great, thank you so much for that.
Yes, and the HECAT in Colorado and Washington. Yes, thank you, Nancy. I should have mentioned the HECAT. Thank you.
Okay, interesting. I never heard of that, so I'll have to do some personal research on that. And so, as I mentioned earlier, we're going to be distributing these slides to all those who participated. We'll be sending out an email. And that email is also going to contain a short evaluation for this webinar. And you do have to complete this evaluation if you would like to receive a letter of participation. Once you complete the evaluation, it's going to take you to a thank you page, at which point you can download that letter. Don't navigate away from the page, because if you do, you'll lose that ability to download it. We can get one for you, but it's just a lot easier if you are just able to do that. We're also going to be posting the recording of this webinar and any of the resources mentioned in this presentation about in the next week or so. So you can look out for that on our website. And that website will be linked in the email I'm going to send. But from CADCA, we just want to thank Ms. Hertz for the wonderful comprehensive presentation on your work and your commitment to providing relevant and current material. And thank you to the participants of the webinar for your comments, questions, and insights. We had a really great Q&A. This is the best one I've seen in a while, so really appreciate that. And we hope to see you at another one of our Research into Action webinars. I hope you have a great rest of the day. And yeah, thank you again, Ms. Hertz.
Thank you so much. Have a great day, everybody.
Bye.